If we can just get started, welcome everybody. This is the last Controversies in Cardiology that we'll be doing this academic year. We're starting up again in September. Welcome everyone who's watching live and those who are going to be watching it on webcast. I want to thank Guy and Ricardo for setting this up, and we have the film crew. I want to thank them as well for putting this all together, and I understand it's had very good reception on the internet. I think part of it really speaks to the quality of the programs, and it speaks to the effort that the fellows put in, and Dr. Fuster usually moderates, and Dr. Reddy is going to be pinch hitting today. Those of you who may have watched the partner course, CC Live Cases, Dr. Sharma had around 1,000 people here watching his live cases, putting on one of the best conferences of the year. If you didn't catch it, you may catch part of it on the web. And it was an excellent course. We want to, of course, congratulate all of the fellows who are graduating cardiology program here and in other institutions who may be watching on the webcast. We'll introduce you to all the new fellows next year, starting in September. Just to let you know about the visiting professors we have next year and the controversies, the topics, we really don't choose until shortly before, so we can keep it as topical as possible. In September, Mark Cohen from Newark Beth Israel, who's a former graduate of the program here. October, Spencer King from Emory in Atlanta. In November, Andrew Marks from Columbia, also a graduate of Sinai. In December, William Stevenson, Brigham and Women's. In January, Dr. DeMaria, editor of JACC. In February, Andrew Epstein, electrophysiologist from Penn. In March, Joe Lascalzo from Brigham and Women's. In April, Ken Ellenbogen from Virginia. In May, David Holmes from Mayo Clinic. And in June, Chris O'Connor from Duke. Today's topic, we were really very pleased to welcome back a native from New York, Mark Josephson, who Dr. Fuster will introduce more formally. And you're going to be privileged to listen to John Wilner, one of the fellows, present a short monograph on the topic from today, which is treatment for ischemic and non-ischemic VT, pharmacological versus device versus ablation. John?
Good afternoon, everyone, and thanks for coming. Ventricular tachycardia is a wide complex arrhythmia originating from the ventricles, characterized by a ventricular rate greater than 100 beats per minute and a QRS duration greater than 120 milliseconds. Sustained monomorphic VT is categorized as VT lasting longer than 30 seconds, though shorter episodes causing hemodynamic compromise or significant symptoms such as syncope are identical in both management and mechanism. There are approximately 450,000 episodes of sudden cardiac death annually in the United States. 62% of these events are attributable to underlying coronary artery disease as the precipitant for episodes of VT or ventricular fibrillation or VF. Despite improvements in the detection and treatment of coronary artery disease and the popularization of the implantable cardioverter defibrillator over recent decades, the rate of sudden cardiac death has remained relatively stable due to an aging population with increasingly complex myocardial and systemic disease. Approximately 50% of CAD-related deaths occur as a first event without prior knowledge of underlying coronary atherosclerosis. Traditional risk factors for coronary artery disease poorly predict the risk of ventricular arrhythmia at an individual level, highlighting the need for further understanding of the current risk paradigm. Broadly, ischemic VT can be categorized on the basis of its temporal proximity to the ischemic event. Early VT occurs within 48 hours of an acute myocardial infarction. Late and chronic VT occur after 48 hours and 6 weeks, respectively. The timing of VT relative to the ischemic event is an indicator of both arrhythmic mechanism and downstream prognosis, and therefore portends important immediate and future therapeutic implications. Options for the management of ischemic VT have evolved substantially over the past 2 decades. Major trials in internal cardioverter defibrillators, both in patients with ischemic cardiomyopathy at risk for sudden cardiac death and in patients who have survived a sustained ventricular arrhythmia, have documented a significant mortality benefit over optimal medical therapy. Catheter ablation has come to play an increasingly large role in the growing population of patients with recurrent ICD shocks as both a complement to and a replacement of antiarrhythmic drug therapy. While these modalities in aggregate have led to notable gains in both the quality and duration of life in many patients with or at risk for VT, there are others within this cohort who will derive minimal or no benefit from current therapy. More accurate identification of a truly high-risk patient population remains an evolving process, one that will become increasingly pressing as the ischemic cardiomyopathy patient population continues to grow. Thank you.
Thank you, Jonathan. Interesting topic today, and I appreciate your efforts. And it's my task to introduce Mark Josephson. Mark Josephson, you look at him, undoubtedly, he looks like a New Yorker. And if you talk to him, there is no doubt about it. So he was born in New York, and he had his original studies in medicine. He graduated from Columbia University here, Columbia Presbyterian. And then he had the postgraduate training was actually at Mount Sinai, where he was an intern in medicine, and then was a resident in medicine. Then he moved to Philadelphia, where he was a fellow in cardiology and in clinical electrophysiology. Now, I have to go very slowly because he has accomplished so much. At the University of Pennsylvania, he then became assistant professor of medicine and then associate professor of medicine. Then he had a number of positions: director of medical intensive care unit, director of clinical electrophysiology, subsequently director of electrophysiology program in arrhythmia service. This is when I actually met him for the first time. It was in the 1970s. And then finally was chief of cardiovascular medicine in the division of cardiology here at the University of Pennsylvania. Now, subsequently, he moved to Boston, where in 1992 he became professor of medicine with tenure at Harvard Medical School. And then this became the Herman Dana Professor of Medicine. The hospital where he really spent a great part of his life was Beth Israel Hospital, where he became the director of electrophysiology, chief of the division of cardiovascular medicine, and most recently, since 2007, chief academic officer of the Cardiovascular Institute, which entails Beth Israel and Deaconess. So I like to point out a few things. I think to start with, Mark Josephson is really a pioneer in the field of electrophysiology. I remember Dr. Wellens in Holland. I remember Mark Josephson. I remember Ken Rosen in Chicago. When I was a fellow, these were really the people that were the absolute doers and starters of this particular field. And he was so enthusiastic at the University of Pennsylvania when I met him for the first time. He actually didn't have time to talk. He was going from case to case. I still remember waiting until he finished these cases, which that time even took longer. But I remember vividly how wonderful it was to know him. Tremendous energy. He became president of the American Federation for Clinical Research, chairman of the American College of Cardiology, Electrophysiology, and then he certainly became a member of the American Society for Clinical Investigation. Now, Mark has numerous awards and recognition from all over the world. Honorary Master of Arts, University of Pennsylvania, Medical for Excellence, Columbia University, Physician of the Year Award, Philadelphia Medical Society, First Resker Award, the Cardiovascular Research at the Resker Foundation in the Netherlands, William Harvey Award, NASPE Distinguished Teacher Award, NASPE Pioneer Award, Lifetime Achievement Award of the University of California, San Francisco, Gifted Teacher Award of the American College of Cardiology. In just these last few months, actually, American Heart Association Paul Dudley White Award in 2012, 2013. So, from the most academic point of view, I mean, when you go to his curriculum between 1974 and recently, he had actually 12 NIH grants, with 4 of them recently significant program projects. And aside of this, he has been the PI or the co-PI of a large number of studies that have to do with the electrophysiology field. Now, finally, when you look at his publications, these are near 500, and I think he has touched every conceivable corner of the electrophysiological field. I must say that I am ahead of him on one thing, is on lidocaine. He wrote the first paper on effects of lidocaine in American Heart Journal in 1972, and I was with Desmond Julian in Edinburgh, and we were the first who used lidocaine, and I still remember the first patient. I was a fellow in the CCU at night, and that's where lidocaine actually started, and this was in Edinburgh, which was in the late 1960s, 1969, 1970. Well, Mark, it's a pleasure to have you here today. It is a privilege. You were part of Mount Sinai a number of years ago. You're part of Mount Sinai today. Let me just give you this plaque, which I always have trouble in getting the check somewhere. Well, put this in your pocket. So our faculty and fellows of our institute here are grateful to you, and this is for your outstanding contribution to medicine. And this is the Anandi Sharma, visiting professor, and the Simon Dack Memorial Lecture. Thank you very much, Mark.
Thank you.
Thank you.
Thank you.
So now we are going to ask Dr. Vivek Reddy. I noticed him a little nervous before we started, but Dr. Dukipati is coming. Dave Mehta is here. Good. Mark Miller, Dr. Pinney, and obviously Jonathan. Okay, so you all can sit, and I wish you the best.
You're on here too.
No, I'm not.
You're not? Yes,
No,
you are.
I went to rest today.
You're the rest.
Just Goldman gave me a rest.
Okay. Well, thank you, Dr. Fuster. It's an honor for me to moderate this session today. As Dr. Fuster already said, Mark has been a pioneer in our field for a very long time, and we're going to talk about one of the aspects that he's sort of led, which is the whole field of management of ventricular tachycardia, particularly with relation to surgical and then catheter ablation. As is sort of detailed in Jonathan's monograph, the field of trying to understand ventricular tachycardia really began with surgery. So there were a couple of major centers, 2 or 3 major centers in the United States and abroad, where surgical mapping of ventricular tachycardia was performed. This is, of course, before defibrillators were available. Mark led probably the most important center, which was Penn, and they did a huge amount of work in terms of subendocardial resection to treat patients who were at risk for ventricular tachycardia, who survived ventricular tachycardia episodes. And it's from that initial work and the careful mapping studies that he and his team performed that really provided the basis for catheter ablation of VT, at least in the post-MI setting. We understand from those studies in the post-MI setting, the VT circuits are not single circuits, that we think about this as a mass of arrhythmogenic tissue from which multiple circuits can emanate. And it was based on that the concept of substrate ablation was born. That is, to first identify the substrate, carefully map the substrate in the post-MI situation, and then to make series of targeted lesions to try to eliminate or to render the substrate unable to maintain VT. And from that came a couple of studies that I want to start off with, and these are a little bit older, but I think that's a good place to start. The first study is SMASH VT. Now, I'm the principal and the first author on this paper, but it was actually Mark's idea. Mark was the one who came up with the idea both of the study as well as of the name, SMASH VT. And the idea of SMASH, which is, of course, been published now, 6 years ago, was to look at patients who had survived a VT or VRF arrest, who also had a myocardial infarction. And then at that time, of course, the standard therapy was a defibrillator. And the question was, well, what if we did more than just put a defibrillator? Because we know that patients who receive defibrillators receive multiple defibrillator shocks. So the idea of SMASH was to take patients, post-MI patients who survived a VT or VF event, and randomize them to usual therapy, which is a defibrillator or defibrillator plus ablation. And what we showed, this was really a 3-center study, but what we showed in 128 patients that were randomized equally between arms, if we look at the primary endpoint, which is the number of patients that received defibrillator therapy in one arm versus the other, it was significantly less in that group that received concomitant ablation. So it was 33% in those patients that received the defibrillator alone. The patients that also received catheter ablation, it was down to 12%, and that was a statistically significant result. From a safety perspective, there were no significant complications, and importantly, if you look at the mortality in the two groups, the mortality in the ICD group was 17%, and the ICD plus ablation group was down to 9%, so 17 to 9%. But that was not a statistically significant result. Now, after SMASH VT, there was another study called VTAC, and this was by Karl-Heinz Cook and his colleagues in Germany, well, mostly Germany. Very similar design, post-MI patients, but there was stable VT, and again randomized to defibrillator or defibrillator plus ablation. And the results were similar. There were more centers, there was 16 centers, and this was published in Lancet in 2010. And what I want to get to from those two studies, I want to get to what's actually happening. So those two studies were published in 2007, 2010. And there were a couple of surveys that were conducted in Europe, and they asked the question, this is the European Heart Rhythm Association Research Network, and they were trying to understand what exactly is typical practice. And this was published in Europace in 2012. And what we see, if you look at the indication for ablation of ventricular tachycardia in the different centers, if you ask the question, what % do this preventative or prophylactic ablation at the time of ICD insertion, what you see frequently was extremely, so the % of centers that frequently employed this approach, that is early ablation, was less than 5%. 80+% of the patients never employed this approach, that is ablation this early. And about 10% employed this approach somewhat rarely, they said. So occasionally they would employ this approach, but not on a systematic basis. Similarly, there was another survey, again, a European Heart Rhythm Association survey. This was just published in 2013. And what was interesting are a couple of things. First, that MR imaging was performed in about half the patients that underwent VT ablation. And we'll come back to that later, about the role of MR imaging. But what was interesting is, again, in the setting of secondary prevention, just like SMASH VT or VTAC, early radiofrequency ablation of VT was performed in over 50% of the patients in only 5 centers and only 11% of the centers. So again, while SMASH VT and VTAC certainly resulted in very nice publications, they don't really seem to have influenced clinical practice that much. So I'm going to start off there. Actually, let me give one last piece of, one last paper I just want to talk about. This was published by the Penn Group about 2 years ago. The Penn Group is a very busy group doing lots of VT ablation. And so they looked at their experience, single center experience, from January 2008 to April 2009. And they asked the question, what, if they look at when patients are referred to them, how do they do? So they define early referrals and late referrals. And late referrals were defined as patients that had 2 or more VT episodes separated by at least a month. So The idea was some patients were referred to them early in terms of when they started having VT episodes. Other patients were referred to them late, that is after they had multiple episodes, treated with medications, etc. And what they found was that those patients that were in the early referral group actually had superior outcome than those that were referred late. So taking all this together, I'd like to start off with Mark and ask, Mark, first, what do you think about the role of catheter ablation after SMASH and VTAC and the way it's been adopted, or I should say not adopted? How do you view this?
Unfortunate. I think that I'm coming from an era where we did surgery, which was the single best procedure we had for preventing sudden death and VT, and nothing has come close. And the ablation that we're now doing is trying to mimic that a little bit. It's surprising how few people even consider an ablation, and I think it's because they think it's difficult. There are not that many people that are willing to underdo this and take it on with a perceived high morbidity, which is not so.
Right.
They say an ICD is easy, takes no brains. I guess that's easy. Whereas to do an ablation takes someone who understands electrophysiology. And in my mind, I would say, who do you want taking care of you if you have an electrophysiologic problem? Someone who understands electrophysiology, or someone who just puts in devices which, in fact, don't prevent the arrhythmia at all, don't address the cause of the arrhythmia, and really is a fail-safe. And, in fact, why they did better in the early prevention of Dr. Morslinsky is probably because of the recurrent shocks that people get for recurrent episodes and the damage that shocks do to patients for recurrent heart failure and even mortality in some cases.
So I want to get back to the shocks and mortality. That's a very important point. But let me just ask, actually, let me just show you. This is another paper that's early access, so it's going to be in press. So this was a center in Japan, and what they did was they retrospectively looked at patients who had structural heart disease that underwent ICD implantation. And they actually did. This is one of the only papers I could find in the literature where they actually sort of followed what we did in SMASH and VTAC. So in half the patients, and this is not randomized, this is non-randomized, but in half the patients they did ablation at the time of implantation, and the other half they didn't. And again, there may be a bias here, okay, because it was not randomized. But during follow-up of 50 months, only 5% of the patients in the ablation group received appropriate ICD therapy versus 65% of the patients that didn't undergo ablation at the time of ICD implantation. That was obviously highly statistically significant. So let me ask you, Srini, when you look at SMASH and VTAC, I mean, you just heard what Mark's impression is. But when you look at your colleagues and yourself, how do you look at this? What do you think is, why are we not doing this? I mean, as you know, we're not doing this either, to be honest, in our practice. Now, part of it is that we don't have, there's only so much time in a day and so much lab time, but that was for Dr. Fuster. We didn't know we need more lab time. But anyway, but what do you think, from a medical perspective, what do you think your colleagues are thinking?
Well, they're probably thinking that this is a very complicated procedure associated with a high mortality morbidity rate, similar to perhaps what was seen in the surgical literature. And often, I think people's experience are based on referring patients very late who are very sick, have received multiple ICD therapies already, and are overall a more severe disease state than the ideal patients for this type of procedure who are early intervention. So I think that's the thing we have to focus on changing, I think. The other thing, I just wanted to comment that, these ischemic VTs that we do are completely different from the dilated cardiomyopathy. I think the success rates of the ischemic VTs are going to be generally better than dilated cardiomyopathy patients, and I'm not sure we can extrapolate this type of results to those with dilated cardiomyopathy.
Yeah, no, absolutely. I want to get to that too. Let me just have one more opinion. Dave, what are your thoughts on timing of VT ablation?
I think the problem really is the selection of patients. If one just steps back and looks at it from the point of view of electrophysiologist in a community hospital where you have patients who come with low ejection fraction, obviously the first reaction would be to put an ICD. Now, I'm not sure whether that's the time when one should consider an ablation. First shock by an ICD probably is an indication to refer that patient for. So I feel that there is a role for ICDs, but the referrals for ablation are done relatively late. Patients are given multiple antiarrhythmic drugs, and when they fail amio and Mexitil, then they are referred. So it will be very difficult to totally apply the results of SMASH VT trial to a large community. And there has to be a way of selecting this group of patients so that an appropriate number of patients could be referred for ablation.
So, Mark, let me ask you to that point. So the question that he's raising, of course, is can we risk stratify these patients better to make it so that the control rate would be even higher than 30 or 40 or whatever we saw in SMASH and VTAC? What are your thoughts? And let me rephrase it a little bit differently. How high must the control event rate be in order to justify the intervention?
Personally, I think 35% is pretty high. I think that if you select people with tolerated monomorphic tachycardia, that's a different group than the SMASH group. Okay, that's a group that has a 60% recurrence rate. Okay, uniform VT and coronary is a very high recurrence rate. I think a lot of this is the people don't know what we can do, and they don't know how relatively safe this procedure is. It's actually surprising. It also is, I hate to say it, a fear of losing the patient. I think that exists. And the other thing that hasn't been discussed that is an important failure on all of our parts is that we never were able to do a study comparing amiodarone versus ablation in this population. So this is a situation where doctors, anyone can give amiodarone, so they think they can give it, and it's the same as an ablation. And we don't know enough to say that they're wrong.
Yeah, but to your point, by the way, in VTAC, where there was monomorphic VT, the recurrence rate in the control group was 70%.
Right.
So it was extremely high. Let's move to shocks and mortality. I mean, everybody in the audience has probably heard about shocks and their potential negative impact on people. Now, before getting into this, I just want to say very clearly, I think everybody knows this, but just in case there's any question, there's no doubt that ICDs have a mortality benefit, period. ICDs overall saves lives. Having said that, there are a couple of papers, a couple of high-profile papers that suggested that while they're saving lives, they may also have some problems. This is based on some preclinical work that showed that when you deliver an ICD shock in animal models, you have evidence of transient myocardial damage, either a troponin leak, et cetera, or transient myocardial dysfunction. Now, following that, there were two high-profile papers, I think both published in the New England Journal of Medicine. Maybe one was in Circ, I can't remember. But one looked at the mated-2 population, the other looked at the SCUD-HEF population. So the first looked at the mated-2 patients, and what was noted was that if you look at those patients who received appropriate ICD therapy, so an appropriate shock for VT or VF, and then you follow those patients out beyond that point and compare to those patients that never had ICD therapy, the patients that did have some ICD therapy had a threefold increase in mortality. Similarly, in the SCUD-HEF population, if you look at after a first appropriate ICD shock, followed out to 45 months after the shock, those patients also had a threefold increased mortality compared to those who never had an ICD shock. And what was interesting also, in both SCUD-HEF and mated-2, even an inappropriate shock was associated with an increase in mortality. Not quite 3 times, but still a significant increase. And these are all highly statistically significant results. So the question was, why is it? Is it because sick patients are going to get an ICD shock and therefore are going to die later? Or is it that ICD shocks themselves have some negative consequences to patients? And this is still a hotly debated topic. Now, I want to bring up 2 recent papers that both are significant papers and have divergent results. Good for controversies. The first was a paper. Actually, it was presented in abstract form. And I think it's in press. It's not in press yet. Actually, it's going to be published soon, I think. But this is a paper where the altitude database was looked at. So altitude is a type of remote monitoring system. So after patients get their defibrillator, They have the remote monitoring. One of the advantages of this kind of a system is that you're able to monitor exactly how many device shocks the patient has, et cetera. It's important because this particular observational study included a lot of patients. This is approximately 4,000 patients who received a defibrillator for primary prevention were followed. And then they were matched to those patients. So these patients, there are 4,000 patients. And actually, these are 4,000 patients who actually received a shock. So the study looked at 4,000 patients who received a shock either for appropriate or inappropriate therapy and compared to a matched group of patients who never had a shock. Okay? So the couple of results. First, what was interesting, first of all, is that 40% of the shocks were inappropriate, 60% were appropriate. And unfortunately, that's real-world practice. Second, if you look at overall mortality, patients who had their first shock for either monomorphic VT or VF had increased mortality compared to those who didn't have a shock. And that we knew also from MADE IT, and we knew that from Scott Heft. It was also interesting, if you look at inappropriate shocks, so patients that had a shock because of atrial fibrillation, atrial flutter, also had an increased mortality. Okay? But what was interesting is that patients that had an inappropriate shock for some other benign reason, so because of let's say, artifact or oversensing, or for a rhythm like sinus tachycardia, they did not show an increased mortality. So how did they put it together? Well, they said this suggests that the adverse prognosis after a shock is related more likely to the underlying disease. You see, patients who have a VT or VF, they may be more likely to have subsequent mortality. Patients that have AFib or atrial flutter, there's also data that suggests that those patients have a higher risk of heart failure mortality. But if it's the shock itself, then a shock related to sinus tachycardia or to a ICD, lead fracture, that should not increase mortality, and indeed it didn't. So that's one set of results that suggests that shocks themselves are not bad for you, but that they identify patients that are higher at risk. Now, that goes in one direction. But then there's another study called MADE IT RIT, which many of you are probably familiar with. So MADE IT RIT, if I can find it, here it is. This was just published last year in the New England Journal of Medicine. It was a very large study. It's important because this is the only randomized study that's really looked at this information. 1,500 patients. So 1,500 patients were randomly, these again, primary prevention patients, were randomly assigned to either conventional programming or two different types of programming that basically minimized ICD therapy. One of the programming was to say, delay therapy until 60 seconds. The other programming basically said, only deliver therapy for VF. Don't bother to try to treat any VT in the 160, 170 beat range. What was interesting is, now their primary endpoint was occurrence of inappropriate therapy. And as it turned out, not surprisingly, conventional programming did the poorest. So if you just withhold therapy for 60 seconds, or if you just treat for VF, you actually have less inappropriate therapy. And that's not a terribly surprising result. We've seen that in other smaller studies. But it's nice to see that in a big study. But what was extraordinary, at least what's very surprising, is that the patients that had conventional programming had a higher mortality, all-cause mortality, than patients that had deferred shocks or shocks only for VF. So this is the first study, randomized study, that suggests that therapy is not necessarily good for you. I mean, of course the ICD is good for you, but having said that, depending on how you program, you can actually have a mortality effect. So here we have two divergent results, one suggesting that shocks are bad for you, they made it RIT, and then you have the altitude study, which is not randomized, but still a large database that suggests that it's not the shocks themselves, but simply identifying sick patients. Mark, how do you come down on this? What do you think?
I think no one knows the answer. That's why there's a debate. I think that, in fact, it's obvious. People who are sick and are prone to die are going to die, whether they get a device or not. I do think shocks are bad. And I do think that the other aspect of this is if you look at patients who have ICDs and who have appropriate shocks from ICDs and compare their mortality to patients without ICDs, it's actually higher. So the possibility that ICDs actually cause arrhythmias has to be at least in the back of your mind. It's not just the patient, it's that the ICD in a particular patient might be pro-arrhythmic. So it's not so clean as we'd like it to be. I think that, I actually believe that devices getting shocked are bad. There are now at least 2 studies where if you do anti-tachycardia pacing instead of shocking them, you do better, so implying that the shock itself is bad. And that's very important because that's in the same patient population. If you switch them to ATP, they don't have the same problems as if you let them get shocked. So that makes me believe that a shock is bad no matter what.
Okay. What would you do? What's the next study to address this issue? I mean, this is not an easy problem, obviously, to answer, an easy question to answer.
It's the same answer I give to all the questions. We need to understand things better. So we need to understand why people have events. We need to understand how to identify what really is an arrhythmogenic substrate, because if we're going to talk about ablation versus ICD, we have to know that we can actually identify something that's arrhythmogenic. And we don't know that yet. MRI is a tool that is not ready for prime time in this area, but has promise to identify what about a scar makes it arrhythmogenic. Once you can identify that, you may be able to risk stratify patients better. And if we're really lucky and are able to see into the heart and the scar better and with more precision, it may actually help us in the ablation aspect of it. But at the very least, if you can identify arrhythmogenicity in a certain scar structure, then I think that's a better risk stratifier than what we have now, which is ejection fraction, which is kind of lousy.
Okay. Actually, to that point, there are a couple of papers published recently on doing MRI, both preclinically and clinically, trying to correlate what you see on MR versus what's actually performed during electrophysiological mapping. How hopeful are you that that'll work? Just when you look at, the spatial resolution of MR and at least what we think we know in terms of the paths, the circuits.
I have to be hopeful or I wouldn't be studying it. I don't want to waste my time. We happen to have a very good MR group. It's the second oldest in the country, cardiac MR. And we're working on algorithms to make the MR more accurate. Now, what does that mean? It means you have to account for respiration. It means you have to account for differences in motion of the apex and the base of the heart. You have to have references in the aorta and at the apex of the heart. And maybe you'll be able to get to 2, 3, 4 millimeters. Well, that's the size of an ablation lesion, but the problem is that a lot of the fibers that are responsible are 100 micron. And that's fine, you can identify that in an in vitro model of VT, but we don't have that model yet. So I think that would be a good thing to have an animal model where we can actually trace the course of a tachycardia and know what is critical to the circuit, and then do histochemical staining and molecular imaging, connexons of fibers, all the things that you'd like to do, and be able to look at the anatomy. So in vitro, you can look at 100 microns with an MR in a heart that's not moving, and that may be useful. I'm still trying to work on that.
Okay, let's just switch for a second to nonischemic myopathy. Srini, you brought up earlier that I think you said that we're seeing more nonischemic cardiomyopathy patients, and they're more difficult cases. Indeed, there was a paper that was published from Bill Stevenson's group in Circulation last year, looking at their history, or their experience, I should say, of catheter ablation of VT and nonischemic heart disease. And there were a couple of things that were interesting. They had 226 patients that had sustained VT due to nonischemic cardiomyopathy. About half of them were dilated cardiomyopathy, and 15% additional were valvular myopathy. Now, they also included RV dysplasia, which I think is a separate category. But the fact is, their overall success was clearly worse in the dilated cardiomyopathy, and particularly compared to their post-MI patient population. In fact, there was an interesting paper also published, it's actually just online, from Katja Zeppenfeld in Europe, where they also looked at patients with nonischemic cardiomyopathy. They had 45 patients, and what they found was that overall their success rate was not terribly high. I mean, here it is. The complete success rate in terms of during the procedure was 38%. So in only 38% during the procedure were they actually able to eliminate all VTs. In an additional 38%, they were able to eliminate the clinical VT, but they still had non-clinical VT, and the remaining patients were unsuccessful. And I don't know what our data, well, I'll ask you what our data is. You tell us if it's not that dissimilar. But during their 2 years of follow-up, their success rate was basically 50%. So half the patients had recurrences, the other didn't. Now, I should also say, even the patients that had recurrences, they had fewer recurrences than the ones that didn't. So let me just ask you, first, do you think our experience is similar to that?
I think, I don't know if it's quite similar, but I'll tell you it's worse than with ischemic cardiomyopathy. The success rates for this are when we suspect we know where the VT is coming from. For example, if the VT looks like an epicardial source, we have MR imaging that shows subepicardial scar, then we go in and we have a better chance of success, I think, of treating the clinical VT. If you have a patient with dilated cardiomyopathy who's experienced recurrent shocks and you have no idea where the scar is, you have no idea what the VT looks like, more chances than not they're going to come back.
Yeah, let me just ask, I mean, these are harder cases. In fact, today, you and Mark actually did a VT ablation, one of our failed ablations from, I guess, a couple of weeks ago, and today appears to be much better success. But, you know, some of these patients we fail completely. Frank Marshinsky had a paper last year in which they had 8 patients with recurrent sustained VT. They did 1 or more ablations, failed, and then they eventually brought the patients to surgery. And they had reasonable success. I mean, in 6 of the patients, they either eliminated or significantly reduced the burden. The other 2 patients died of progressive heart failure. Mark, what are your thoughts on this surgery? I mean, I know you're a fan of surgery. You came from surgery. But in 2013, what do you think about the role of surgery?
If you're talking about surgery for non-ischemic cardiomyopathy,
I mean,
Zippo.
grab.
That's a Zippo for that. It's
Okay.
it might have a role in dense scar related to valvular VT. So people who have valves get a reaction around the base of the heart where the valves are, and they get a thick scar. And I think that could be frozen, that could be ablated. I think that's a possibility. In terms of coronary artery disease, I think I want to make an arrhythmia surgery program again, because I don't think we're as good as we could be, or anywhere near as good as the VT surgery was. And I don't expect the mortality today to be the same as it was in 1985. I mean, we were taking patients who were dead, that everybody else rejected. Our mean EF was 27%, 25% of our patients had EFs less than 20%, and we still had a mortality of only 15%. And most of that mortality was heart failure. We never had a mortality acutely from recurrent arrhythmias. And so I think we should look again at this in terms of at least the coronary aspect, because we understand that a little better. That's in part why we don't know anything about the cardiomyopathies, because we don't see a scar on a lot of them.
Well, so let me just ask you, I mean, we have excellent surgeons, but we don't have, as an institution, experience with doing VT surgery. How difficult is it to learn?
I think the most important thing to have is a surgeon who'll listen to you. and that's
Sometimes.
not so easy, but in someone, if you find a surgeon who wants to make a career, and these days it's not in cabbages anymore, and everybody's doing valves, it's an opportunity for them to get some academic recognition, which none of their neighbors has. And it sets you apart from every other institution in the city, or maybe in the country. So I think you need to find a young, hungry surgeon who wants to be more academic than he currently is. And I think if you can excite him, and you have financial support, which is another thing, to allow this to be done, I think it's worth doing.
So, you know, I think one of the difficulties of ablation in the sick patients is obviously heart failure. That's one of the big problems that happens after ablation. Well, it happens before and after. Patients tend to, if they have multiple ICD shocks and they're marinated in amiodarone and lidocaine and procainamide, then you have decreased contractility and LV dysfunction, worsened heart failure, and then after the ablation, you have the same problem. So to this point, I just want to bring up two things. First, one of the things that we've been doing more and more is to use left ventricular assist devices in patients that have severely reduced ejection fractions. Now, we initially did this in just a lot of patients, just partly to understand how to use this, et cetera. And in fact, Mark Miller from our group published a paper, actually it just came out this year, where we systematically looked at the use of the percutaneous left ventricular assist device, the Impella device, and showed that it had a significant effect on hemodynamics and was allowed us to keep the patient in VT to do more careful mapping for a longer period of time. So Mark, could you just make some comments on what you think the role is of this percutaneous LVAD device? And I'll have the other Mark comment on your comments.
That's what I'm worried about. I think it has three particular roles. I think in just the sick patient in which you're going to do pure sinus rhythm mapping and ablation, and I'm talking about the patient who came in, let's say ischemic cardiomyopathy and VT storm, has now been hospitalized for 2 or 3 days. You're taking a patient with, let's say, an LA pressure of 35 at baseline, you're putting them under general anesthesia, and you're exposing them to a 6 or 7 hour procedure. Even if you don't do any mapping during VT, that's still a very sick patient, and they're going to come off the table sicker no matter what. And there is a certain inherent benefit into providing support at least during that 6, 7, 8 hour procedure. From our own data, we demonstrated that you can bring the filling pressures back down to the baseline value even after 8 hours of anesthesia and 5 liters of fluid. So that's one benefit. Whether or not it's worth it from a financial standpoint is a secondary point. The second patient population that's also very useful is the one that Srini was referring to. So you have patients, especially the non-ischemic group, in which there is no substrate to ablate during sinus rhythm, and the only way to target the VT is during VT, during entrainment activation mapping. These patients with ejection fractions of 15% with class 3 heart failure at baseline, you'll maybe get 1 or 2 minutes or a couple of minutes during VT, which you can map, and then you have to terminate it. Now, if you do that 6, 7, 8 times a procedure where you're constantly either pace terminating or having to externally defibrillate a patient, that patient also becomes much sicker by the end of the procedure. And then there's the overall inherent benefit of the patient post-ablation, which is you're essentially, I think personally, at least from our experience, it seems to be, although we haven't borne this out because it was a small number of patients in the study, is that your hospitalization time is shorter, your time under endotracheal intubation is shorter, and your time in the CCU is shorter, at least compared to what it seemed like before we were using the PLVAD devices. So I think that the patient population is extremely useful for is the non-ischemics in which you need to map during VT, as well as the patients who are entering the lab in already a somewhat critical state.
Mark, what do you think about this? What's the role?
Well, I think in the non-infarct related, which I like to call instead of ischemia, non-ischemic, infarct-related cardiomyopathy, I think in that group that has no markers for what to ablate as a substrate, I think the long-term success rate, whether you put them on bypass or anything else, is awful. It's a waste of time. It may make you feel good that you did something, but I'm not sure it's going to make the patient feel good. In terms of the other patients, there are different ways to handle it. So I think it's a reasonable approach. We do things a little different. I don't like to have a patient under general anesthesia for 8 hours because I don't think that's a good idea. And what we do in general is we give inotropic support and diuretics to keep the pressure down. So, and we have a pretty good outcome in terms of tolerating the tachycardia, tolerating the ablation, and going home. I don't know if the Impella is better. I think the other thing is the Impella requires you to do a transeptal ablation of the endocardium. Epicardium is very good for it. So if you have a rare infarct-related VT with an inferior infarction that has a subepicardial area, then I think it's very good for that. It's an expensive device. So I think that we'll find out about what the government's going to reimburse down the line, because right now there's no obvious mortality benefit, and people are going to be looking at costs now and mortality benefit. I think that if you can really, and I would really try to document anything you can for rehospitalizations or any kind of outcomes data to support the use of that, because I think it's going to be a tough sell unless we have that.
Yeah, no, I mean, look, we don't have any randomized data that answers the question whether or not the cost of the device is offset by less hospitalization. That's the data that we need, for sure.
There is unpublished data that's under review now that's showing that, it's not randomized in any way, but shorter hospitalizations in patients who underwent PLVAD support. But I do agree with you but I guess the other question is, if the device cost $1,000, would you be more likely to use it?
Then 85,000, I mean, it costs a lot of money.
No, it's not 85.
It's not $1,000.
20,000.
What the hospital bills is, and they hope to get
Yeah.
reimbursed is $85,000.
Right.
That's not going to happen, okay? So I think that's a real issue. I think that you need to look at comparable patients. You can't just take data from different hospitals. You need to look at one hospital, the similar operators, because a lot of this is really operator dependent as well. So it's very hard to do a study that is applicable to the world. And same thing for the initial one. There are people who are better than other people, and there are patients who are better candidates, and we don't know how to identify them right now.
Sean, let me just ask you about the Lvad population. It's interesting. There was a paper published this year, actually last year in Heart Rhythm, where the Cleveland Clinic, they presented their experience. They had 611 patients who received ventricular assist devices. And of those 611, they had basically 21 patients that were referred for EP procedures, for VT ablation procedures. And, they had a reasonable success rate. It turns out, actually, that the cannulation site was not actually the most common source. It was the intrinsic scar, but that's a small detail. I guess the question I have, from an EP perspective, we love doing ablation on VADs because you can keep the patient in VT, you can keep him in VF if you want, and there's no problem. We can sit there and map all day if we wanted to. So I guess the question from a heart failure perspective, you invest a lot of time and energy and effort, and these are very sick patients. How do you look at them when they have VT? What do you consider the role of VT ablation?
No, I think it's important to say that the presence of the LVAD changes the natural history, not only of heart failure, but of ventricular tachycardia in these patients. And we've certainly had numerous examples of patients who have been in sustained ventricular fibrillation, sustained ventricular tachycardia, and are ambulatory. They may not be ambulatory or walking very quickly, but they are ambulatory and awake. And I learned that the hard way, a very humbling experience when I was a first-year cardiology fellow, which I'm happy to share at my expense some other time. But it is true that these devices, both the pulsatile devices and the continuous flow devices, can support circulation in the absence of an organized rhythm. And so that led us to ask the question, then, do you need to have an ICD? Is the ICD going to be life-saving? And I just mentioned Alan Enriquez did a fantastic job reviewing our experience, looking at LVAD-supported patients who have an ICD versus those patients who don't have an ICD or an inactive ICD, and showed that there was no survival difference between the two. There weren't any cases of sudden cardiac death in those patients who didn't have an active ICD. And so we've incorporated that into our own clinical pathway. You probably have seen we haven't referred a lot of patients for ventricular tachycardia on LVAD support. If patients come in and they do not have an ICD, we very infrequently will put one in place if they are LVAD supported. If they do have an ICD, we'll have a conversation with them and ask them whether or not they want to leave it active or inactive. And this is not what other centers across the country do. Bruce Willikoff and I politely disagree at Cleveland Clinic, and as you can see, they're much more aggressive about treating these arrhythmias. So I don't think that on a single center experience, we've written the final chapter. There's still a little bit of debate. Alan's paper will be coming out shortly. There's a second series from Columbia looking at an almost identical number of patients and identical outcomes.
Mark, any thoughts on the VAD patient population? Any additional thoughts?
I think that I sort of agree with the conservative approach I'm hearing to the left. I think that I know Donna Mancini very well at Columbia, and initially when you have VT, sometimes you put a VAD in, the VT stops. Okay, we're unloading the heart, and maybe a good thing. But once you're living with these destination VADs and they have VF and they're walking around fine, you can only hurt them more. So I don't see the need to put another $30,000 into that patient for who knows what.
So, John, let me ask you, as you've been reading the literature, preparing for the monograph that you wrote, and after hearing the conversation, you already heard from Mark the need for doing more basic research to understand physiology and pathophysiology better. What are your thoughts in terms of clinical research? What are the questions that you'd like to answer? And try to be more specific, not general questions like, does VT ablation improve mortality? Or maybe that is it.
So, I think you referenced one of them when you spoke briefly about the Japanese paper by Hayashi, which again was looking at sort of the role of VT ablation as a primary prevention procedure almost in lieu of antiarrhythmic therapy. So I think the VT ablation at least seems to be heading in that direction, since, as we all know, antiarrhythmic therapy can be beneficial in a very specific subset of patients, but in a lot of other ones it does harm. If you look even in Scudheft in the ICD era, patients with class 2 or 3 heart failure who were put on amiodarone therapy, some of them did not at all better, and some of them in fact did worse. So is there a role for VT ablation in lieu of antiarrhythmic therapy? And then I think also, this was also alluded to before, but in the ICD population, right now we're using EF purely as our stratification tool for these patients. And as the healthcare system continues to evolve and as our ischemic cardiomyopathy patient population continues to grow, that's not going to be a sufficient means for figuring out who needs an ICD. So who those patients are who truly derive benefit from an ICD beyond EF, is it the patients who, we're putting them into patients who are in their 70s and 80s and 90s? Well, the population in most of the primary prevention studies was, patients, they were 65 was the mean age. They were mostly men, so women weren't really considered. So who are those patients who are really going to derive benefit from the device in the future?
Mark, any thoughts on the elderly, the population? We didn't really get into that.
I think that the one thing that hasn't been talked about that should interest you is the fact that in this group of people with infarct-related cardiomyopathies, atrial fibrillation is a proarrhythmic arrhythmia. Mm-hmm. And it is a cause of many of the VTs and VFs that ultimately get shocked. So I think failure to recognize it, and hence failure to deal with it, is an error that is preventable. I think it's related to, irregular rhythms producing enough heterogeneity and refractoriness and conduction that it's proarrhythmic. And it's less so in non-ischemic cardiomyopathies. So
you think AFib is worse than the ischemic myopathies?
Absolutely. And I think it needs to be taken care of. It's somewhere around 7% of all VT episodes are initiated by atrial fibrillation. Mm-hmm. That's a pretty substantial number, particularly when you think that the ones that have it are going to have it again and again, and they're the ones that are going to get therapy. So I think that's something that people have neglected. I think that could be added on to one of your clinical trials as well.
Yeah, are there any comments or questions in the audience on anything related to VT, or anything for that matter? Because otherwise I'm going to end up using up all of our time.
Can I ask one question, Dr. Josephson?
Yeah.
Everyone talks about the fact that ICD shocks are worse, and I think MATID RIT seems to promote that idea that having an ICD shock is bad versus ATP therapy, for example. Do you think that has anything to do with the way in which the patient is treated after the therapy? Because lots of patients have ATP therapy at home and they don't come to their physician, let's say, for their 3-month device check, and then we notice it, versus an ICD shock almost always initiates some kind of intervention on either a physician or a hospitalization. And do you think that we or the hospital is doing something different to the patients that's changing their mortality versus ATP? Are we giving them antiarrhythmics in high doses?
I think the major thing you're doing is admitting them. Okay, once you admit a patient to the hospital, you're subjecting them to all sorts of mischief. And if they got a shock because they had an arrhythmia, that's what the device is supposed to do. So the first thing is to talk to them and see them as an outpatient. And many of these things can be taken care of as an outpatient. It's when you get VT storm and things like that, then you admit them. And that's where we get involved, both in ablation and potentially use of drugs or more manipulation of the autonomic nervous system, for example. But I think the biggest mistake people make is anytime a patient gets a shock, come to the ED admits them, and then they're stuck in a hospital as an unnecessary admission. The government gets mad at us because they had a one-day admission because we throw them out the next day, and it's just awful. Then they get, nosocomial infection.
Okay, Mark, I think it's 6 o'clock now, so am I pretty much done with my time? Oh, go ahead.
Do you ever see using VT ablation as the sole therapy to eliminate the IC?
No, that's a great question. Let me give my answer, and I'll have Mark comment. There are rare patients that we see, post-MI patients, who have preserved ejection fraction and have VT, and have stable VT. So that's a little unusual. I mean, if you have a patient with preserved ejection fraction, the scar tends not to be so large, and if it's not so large, if you have VT, it tends to be faster. But again, there are patients that have stable VT. That patient population doesn't fit in any of the ICD prevention trials. And those are the patients where we've done VT ablation, and then if we can't get any induction, then not give an ICD, because we know that they're not going to necessarily get a mortality benefit from a defibrillator. Again, these are rare patients. We see one a year or something like that. There is interest in this in Europe. There's a study by Christian Dechieux in France where they go through this protocol in patients that come in with stable VT, regardless of ejection fraction. They're usually low EF, of course. They first do a VT ablation, then they do program stimulation. If they still induce VT, then they go to defibrillator. If they don't, then they don't put a defibrillator, wait like 3 weeks, repeat the EP study, and if they induce VT next time, do another VT ablation. And if not, then they put a defibrillator. So they go through this decision tree. It was a very small study, 40 patients or something like that, and ultimately in about half the patients, I'm not going to get the numbers exactly right, but in a little less than half the patients, they put an ICD. When they looked at mortality, in the patients that got the ICD versus those that didn't, statistically it was no different. In fact, the ICD patients actually had worse mortality than the ones that didn't. Again, this is a small patient population, but there's certainly interest in looking at this. But it's tough to conceive a trial that would actually change practice, at least in my mind. Mark, what do you think?
I believe in it. So if you look at tolerated VT, overall, the incidence of sudden death is about a little over 2% per year. ICD is not going to change that at all. The only study that suggests that it does is AVID, which is totally flawed, and the data are misinterpreted. So I think that particularly in single vessel disease, the sudden death rate is almost zero, with almost a 10-year follow-up in some of our patients. And I have maybe a dozen patients over the last 5 years who've had infarcts with EFs ranging from 30 to 40, not much higher, usually anterior infarctions that I see, who don't want to have an ICD, and I sit down and talk to everybody. Do you think you could ablate me, doc? And I try to ablate them, and if it's successful, I don't put a device in them. Now, I would tell you that I would probably be considered a lunatic by 99% of the electrophysiologists in the United States, but I don't think having a device is a good thing, and that's if you don't need it, and if it can't improve your survival. And I don't think the data are that it can improve your survival, and it certainly can hurt you. So I try in people with stable VT, particularly single vessel disease. The downside is the deaths are multi-vessel disease, a plaque, and you have a heart attack and VF. You can't stop that. Nothing can stop that. But short of that, I think it's a reasonable thing to do. And I practice what I preach.
Yeah, I mean, OUS, only about 50% of the EPs would think you're a lunatic.
Well, maybe in this hospital.
No, in like China and India, people are doing VT ablation because defibrillators are so much more expensive. Brazil, I think, to a certain extent. But anyway. Yes, Sandy.
Yeah, I gather, correct me if I'm wrong, that most of this VT problem occurs in people who you don't suspect it's coming and they have a coronary thrombosis, and as opposed to what you're talking about, I assume, because half the people that present for the first time they just drop dead.
No, it's not true.
So that would be the bigger public health issue, I guess. And so my question is the following. Is there any evidence at all if you have someone you think has, never had a heart attack, is at high risk for heart attacks for various reasons, is there any evidence at all that prophylactic beta blockade is appropriate, it's something we should do for these patients? And does anybody look at, for people with identical coronary thromboses, why some people have defib and other people don't? Are there genetic predispositions on top of the usual mix that would isolate people and make you worry about them more?
Okay, so, yeah, I think this is a complicated, you asked several questions there. I thought you were asking something different than what you ended up asking. So first, just to be clear, the patients that have defibrillators post-MI dilated cardiomyopathy, when they have VT, VF, or VF episodes even, but usually VT episodes, it's not usually an acute coronary event.
I'm not talking about it.
Okay, so I just want to make sure okay, got it. So you're just saying, what you're saying is there's data, as you're well aware, that sudden death for the first time, there's acute coronary thrombosis in a certain number of patients. That's what you're suggesting, or asking about.
Yeah.
And you're asking, can we affect that?
Right.
Mark?
No, we're not good enough to do that. And even in that group, the acute coronary thrombosis isn't as common. Coronary disease is common. Having thrombus in the coronaries is common. To have a heart attack is not common. Okay, so that's a little bit different. To have a heart attack is not common. I mean, we don't know what to do. I think beta blockers, everyone loves beta blockers. Put it in the water. If you have coronary artery disease, it's a reasonable thing to do, particularly if you have a family history. So family history, if your one parent dies suddenly, your risk is increased. If both parents died suddenly, you have about a 16-fold increase in dying suddenly. There are some genetic abnormalities that are associated with sudden death. And it's also different in different racial distributions. So it's not a simple thing. So certain people have a higher incidence of sudden death related to sodium channel genes. Other people have different reasons that they might have sudden death. But the GWAS studies that are being done now haven't really been able to say this is the answer for all sudden death, because it's different in Asians, it's different in Spanish-speaking people, it's different in American whites and African Americans. The incidence of sudden death is different in all of them, and the mechanisms are different. So you're asking for something we all like, but I'm not sure that I'm going to be around to see that happen. I'm quite sure I won't.
So beyond statins, probably not much else at this point. I think we're going to go ahead and close with that, otherwise you're not going to make your plane. So, Mike, thank you very much, and good discussion. Yeah.